Greetings from New York City and Columbia Business School Executive Education. My name is Scott Gardner, and I'm very happy to be here today with Professor Stan Kachnowski for the Understanding Digital Health webinar. Before I introduce Stan, I'd, as always, like to go over a few quick logistics for the webinar. A recording will be made available and sent to you after the webinar. If you'd like to tweet about this webinar, please do so at #CBSExecEd. And as always, we encourage you to upload your questions throughout the webinar, and we'll get to as many of those as possible in the last 10 minutes. Right? It's my pleasure to introduce Professor Stan Kachnowski. He's an Oxford-trained researcher and an expert in the efficacy and diffusion of digital health, including electronic health records, wearables, predictive algorithms, and precision medicine. He is the chair of the Digital Health Testing Center, HIT Lab, and the faculty director of our upcoming Digital Health Strategy Executive Education Program. It's great to be with you today.
Thank you, Scott.
So I'm going to leave it to you, and I will join you at about 20 minutes from now, and we'll go over some questions together. Sound good?
Perfect.
All right, great.
Well, thank you, Scott, and thank you, everyone, for joining us today here at this program. Very excited to explain a little bit about digital health and start with its definition. The learning objectives are really not only about definitions, but also insights and the use of digital health today across many different stakeholders. Certainly, hospitals and physicians are where consumers see it on the front end, but we want to talk about more than that. And then at the end, toward the latter part of the 20 minutes, go into more detail around opportunities and challenges that we're seeing across the digital health spectrum, really the healthcare system, not just here in the United States, but globally, because digital healthcare is something that, because of its definition and its breadth of its definition, encompasses a lot in global health as well. That said, with those three key learning objectives, the principal one is, the first learning objective is around the definition of digital health, which was first created by Professor Eric Topol, who comes out of the Scripps Institute in San Diego after doing an enormous amount of great work at the Cleveland Clinic. Professor Topol wrote a book in 2012 called The Creative Destruction of Medicine. And in that work, he describes the digital human. And effectively what he does is he begins to outline this use of binary data to improve clinical medicine. And he takes this field known as bioinformatics, which is the study of genomics, proteomics, exosomics, and he merges it with this field called biomedical informatics, which is the study of electronic health records, personal health records. It looks at all the data that you would pick up from your Apple Watch and those sorts of data sets. And he combines them all by saying simply, what we need to think about is a record, a clinical record for a digital human that takes everything that we can find from human beings that's been turned into zeros and ones and combines it into one human record. And with that definition, set off an entirely new understanding of what digital health could be, of what digital medicine could be. And it began this, what is now becoming a construct, a rubric forming of something that will help not only hospitals and physicians, but also public health systems and life science companies, med device companies, and even groups like family foundations and multilateral agencies and national health systems, as it begins to improve not only the clinical efficacy, but also the economic efficacy of how digital tools can increase access to various medicines and various diagnostics, but also reduce costs for, on a population level, for healthcare as nations and as groups as whole. So this definition has an importance of simplicity. We need to understand that ultimately anything that comes from the human body or surrounds a human that can be turned into zeros and ones, that is the definition of digital health that we're going to use for today. And there are numerous definitions, just to be clear. The most widely seen definition is curated by Paul Sanier, an author out of San Diego, California. And if you Google digital health, you will see his definition as well. And that definition discusses more of the transformational nature of digital health that goes into more detail around digital health's disruptive powers. And that's another definition that's widely used. If you look at the World Health Organization and what the World Health Organization uses as a definition, their definition tends to be more toward public health and global health, more towards electronic health record systems and telemedicine systems. And so what we have is an important term in terms of encapsulating this change that we're seeing in healthcare and life sciences, this revolution, again, not in the term of a revolution like a one-year revolution. This isn't a revolution in medicine and in public health and in healthcare in general that is taking the term of like a 40-year industrial revolution. And whether you started the clock at the advent of the PC in the early 80s, or whether you start the clock at the advent of the internet and the web in the 1990s, or if you want to start the clock at the advent of and the invention of the iPhone and really the diffusion and the adoption of smartphones across our society, we have this revolution that's occurring that'll be anywhere in the neighborhood of 30 to 50 years. And the term definition and the definition of digital health is one which is important to certainly grasp, understand, and glean insights from, which we'll talk a little bit about now as well. So when you look at the definition of digital health, it's important to remember all of these different data sets, all of these different components of human data, whether it's the individual human or the population health of humans. And when we look at what insights we can glean from, and again, as a scientist and as a researcher, having done hundreds of digital health studies, whether it was before the term was even actually created or today, you can see that whether it's in healthcare e-commerce or whether it's in wearables and biosensors, there are tremendous opportunities to glean insights on how either individual health or population health can be significantly transformed by using these digital tools. And what I want to do in this segment, in the next 5 or 7 minutes, is to talk a little bit about some of the research that I've done over the last almost 3 decades now, and just hopefully share with you some of what I've learned and how it's certainly changed a lot of how medicine is delivered as well. First of all, in a study that was done, this is going back almost 2 decades now, in England on a tool called Advoy, which was, and it still is being used, a haemophilia tracking software. I don't know if you remember the old Palm Pilot. Hemophilia patients would actually track their prophylaxis and their hemophilia, their bleeds, their exercise on a Palm Pilot, take it home at night, dock it to the PC, and upload their data to their physician. And that study involved 1,200 subjects over the course of a few years and revealed that those subjects, those patients that actually utilized the Palm Pilot and tracked their bleeds, their diet, their exercise, and their prophylaxis use more aggressively, were seeing significantly better outcomes and significantly lower hospital admissions. And so that was an early study of digital health that showed, and again, the variables could be confounding, maybe not, but it certainly was hypothesis generating, that this use of digital health had some sort of correlation with improved patient outcomes. And again, that was in England, and that was 2000 to 2005, and that was with a significantly chronically ill patient population of hemophilia patients. So that was a good start. And then fast forward now to the Jawbone, again, a wrist-based device. I don't know if any of you own those devices or not, but it tracked activity, both daytime and nighttime. The Jawbone study that we did was 565 subjects over the course of 6 months, and it showed whether or not patient populations and subjects would actually improve their BMI and improve their sleep quality while they saw the feedback loop of their daily usage of an activity tracker. So they could actually look at the Jawbone app on their phone and see whether or not they were exercising as much as they wanted to, their 10,000 steps a day. That was the daily recommended course back then. Now it's 15,000 steps a day. And also their sleep. The Jawbone was able to track sleep during the night and detect sleep quality. And what we found in that study was actually interesting. It really didn't have a substantial impact on either sleep quality or BMI reduction, except for a small population. Within one of the strata of population that we studied, we found that a specific group of women were more likely to change their behavior based upon those natural feedback loops. And so again, that was significantly different than the hypothesis that we had generated in submitting the study to the IRB and in actually formulating the protocol. So again, digital health had efficacy. Digital health showed, or at least we thought, it would show significant efficacy for the subjects in that study, and yet we were shown that it was really not efficacious from either an economic standpoint or a clinical standpoint for the clinical endpoints of BMI, and we also used a standard form from the NIH to measure patient well-being. Another study to look at in terms of actual wearables was a study that we did with an actigraph that actually was able to track congestive heart failure patients. We put a wrist-based device that tracked their activity, again, daytime and nighttime, to determine if activity during the day, i.e., if they were more active during the day, would they actually have a reduced rate of deterioration in their congestive heart failure symptoms. And again, our hypothesis was off on that as well. We had, in collecting the data on these 61 subjects over 9 months, continuous 24/7 monitoring, we found that it was actually the nighttime activity that predicted the rapid rate or the increased rate of deterioration of their congestive heart failure. What does that mean? That meant, and again, this is published in the Journal of Cardiac Care in 2009, that meant that patients that weren't sleeping well were the ones that were seeing the worsening of their outcomes, the worsening of their health effects. And so that was, again, another study that indicated our hypotheses, originally expected deterioration of heart disease because of daytime activity, were off and were significantly varied than what the outcome was. The point here is that digital health, while oftentimes we think we see the intuitive, we think we know what to expect when we put together a device or an app or some other tool digitally with patient populations, we feel like we're confident in knowing what those outcomes will look like. That's actually not the case. In study after study, what we're finding is that the outcomes are much different than we'd predicted, and that the hypotheses that we had first written about were actually not ones that had come out at the end of the day. The last point I want to make, the last anecdote I want to share, is about a study that was done in Africa. Again, digital health is very much a part of a global movement. It's part of a global infrastructure effort, and certainly if you look at countries like Ghana or India, other nations around the world, you'll see that digital health oftentimes is trying to leapfrog current medical systems that even here in the United States we're accustomed to using. So in Ghana, the study was, again, it was facilitated by funding from the Gates Foundation, and it was a technology developed by the Grameen Foundation called MOTEC, the Mobile Technology for Community Health, and it was a nurse-based voice messaging system that would be delivered to new moms that were 0 to 12 months after birth, and it allowed them to utilize this sort of, it allowed the nurses to utilize these messages to vast numbers of new moms in Ghana. And we looked at the efficacy of 96 voice messages being delivered to these new moms to see if it increased vaccination rates, if it increased breastfeeding rates, malaria kits, and clean water tools. And what we found was, from the beginning, from our hypotheses, we assumed that it would increase the rates of all of these sorts of interventions for reducing infant mortality. What we found was, a lot like you, when you get messages from your pharmacy to pick up your prescription at your local pharmacy, a lot of times you'll just either delete them or you won't answer your phone. So we found that the mother's behavior and the interventions that actually worked were simply the breastfeeding and the reminders to breastfeed. And again, that showed that infrastructure and any kind of disruption in their daily activities, any kind of activities of daily living, whether it was their working or their child rearing or whatever it might be, they were very unlikely to disrupt those sorts of behaviors, those sorts of practices, those sorts of habits, to do something like walk to a clinic that would be an hour away, take a day off from work, and then have to pursue a vaccination that they weren't quite sure or confident in. So these are the sorts of studies that when looking at digital health, we begin to see that it is a very complex field. Digital health is not predictive. It's not something that can be easily seen as if we develop this tool, they will use it. And in fact, what we've seen over the last 10 years, particularly given the ramp up in investments, and just to give you an idea of what people are investing these days into digital health, it's in the neighborhood of anywhere from $1 billion to $2 billion a year, and that's just your US-based statistics. We're finding that these sorts of investments are something that are having significant issues actually making their way into either patients' hands or into hospitals or into health plans or life science companies. And what we try to do when we're looking at the diffusion of digital health, we try to find markers, if you will, that will help predict the more likely diffusion and uptake of an adoption of a digital health tool. And that's, I've got about a few minutes left here, that's kind of the opportunity section of the webinar today. And that really is, as an investor or as a major institution, whether it's a hospital, a health plan, or a life science company, where are the opportunities for you and your institution, whether you're an executive in the C-suite, a VP level executive, or you're managing a department? Digital has a number of opportunities. It has the short term in terms of being able to do what you're doing today, but do it for far less money, or at least somewhat less money. It has the opportunity to allow you to work smarter, not harder. So can you do more work and have more productivity by using the same number of labor units? And can it have an impact on your quality ratings? So if you're a hospital and you're looking at digital tools, where's the opportunity for you to bring that into your system, to integrate that into your system? And I think the number one word here is integration. We're seeing significantly high barriers of taking a digital health tool, whether it's something as simple as an Apple Watch, and trying to integrate it into either an electronic health record system or an electronic data capture system or a care management system at a health plan. These sorts of integration points are turning out to be the vast barriers of the diffusion of digital health into and across the majority of large enterprises and institutions. And that is really to say that on a B2B level, there are significant opportunities. If you look at Keytruda from Merck, again, a nice digital health play. Merck invested carefully. They very nicely crafted their clinical trial with patient populations that met specific genetic requirements, and they created a genetic tool to help actually stabilize the drug usage within patient populations that were going to actually meet the criteria and actually have that drug be used in an effective way. And if you look at ResMed, for instance, it's a sleep apnea device being used at home. Again, another great case of digital health diffusion happening because it was integrated into a payer market and it didn't require significant enterprise level integration into care management systems or electronic health record systems. And finally, if you look at AliveCor and if you look at iRhythm and what they've developed in terms of an actual heart attack detector, you look at now something that is significantly reducing costs for health plans. So why would health plans all of a sudden want to run toward these sorts of heart attack detection devices for patients suffering from AFib or DFib? Well, of course, they're going to reduce hospital admissions, they're going to reduce lengths of stay, and they're going to reduce the readmissions that occur after an event. And so the simple fact of integration with that health plan system, with the health plan in general, based upon the return on investment, the integration costs there were much, much higher, were much, much actually higher than you might see in another app or another device, but the cost savings were also higher. So it's important to see that integration as a focal point for digital health invention, adoption, and eventually diffusion is a core component here. And it's absolutely critical to remember that of all the work that's being done in digital health, it's important to know that patients have to be able to utilize these technologies. And you've had in past webinars from Columbia Business School, lectures and talks on design thinking. And design thinking is a big part of digital health diffusion, and certainly one to take careful notes on, and to certainly understand the patient centricity in digital health as the adoption cycle widens and as it improves. And ultimately think about platform solutions when you're investing or when you're looking to bring in new technologies, new point solutions. Try to stay away from single point solutions and think more about how does this point solution fit onto another platform that my enterprise is already using. And I see that my time for the individual part of this webinar is over, and I'm going to invite Scott back into the frame here so we can continue our conversation and take some questions from the audience.
Thank you very much, and it's so interesting, such great information. It's the future. You know, it really is the future, and so I'm excited to be a part of this with you.
Great.
We have a lot of good questions that came in, so
Good.
let's get to those,
Okay.
all right? So the first one is, and I like this one because it's kind of, you know, when we have our people, the people who are watching right now, we really want to say, like, well, what do they do with this information? So the question came from Amina. How should I be using digital in my institutions today?
That's a great question, Amina, and a lot of it depends on which institution you're coming from. In healthcare, generally we look at about 9 major institutions that affect the global health system, and they range from certainly providers to health plans to life science companies and med device companies to family foundations, national health systems, multilateral agencies, certainly patient advocacy groups, and depending on the organization, and this is where the complexity and oftentimes the contradictory nature of digital health presents issues for institutions, is that it is significantly dependent upon the population you're serving, because every population uses digital differently. A population of moms in Ghana, they have an entirely different digital profile than a population of moms in Manhattan. And I think when we look at an institution, we're really trying to understand what the enterprise legacy systems are looking like, what populations are they trying to manage and trying to serve, and then, you know, just fundamentally, what are their success metrics? So great question, but absolutely one that's filled with more questions on top of that.
Next question is from Abhishek. How important is patient data in digital healthcare?
Yeah, patient data is the core of digital health. Again, if you look at either Paul Sagnier's definition on Google, when you Google digital health, you'll see Paul's definition out there. Or if you go back to Professor Topol's original definition, you'll see that at the base of both of those, we're looking at this element of zeros and ones. And so patient data and how it's generated, the quality of the data, there are 7 variables for patient data quality to be tracked, things like timeliness, consistency, cleanliness, other misfit kind of alphanumerics in the data field. Those sorts of components of patient data are critical because, as you're seeing with machine learning and some of the technologies that have been invented around cognitive computing, machine learning, AI, as some people like to call it, you'll see that, in fact, a lot of the issues in having positive results from those emerging technologies have been raised because the data quality is not high. And anyone who's worked with healthcare data knows that it's generally not easy to work with, and it needs a lot of cleansing, and the integration is also very difficult. And so patient data is at the root of any digital health project.
This is an interesting question, and I think it goes to culture, creating a culture with, you know, with this digital revolution, which is how do you get over, this is from Shona, how do you get over resistance from clinicians, those afraid of technology is replacing them?
That's a great question, Shona, and thank you for asking it, because for almost 28 years of my teaching career, I've been hearing and reading that physicians are technophobes, and I would posit that that is exactly the opposite from the truth. If you think about clinicians and physicians, they have to recertify by taking a board every 5 years, much of which is about the newest technologies that are out there, whether it's molecular or device-based. Physicians they're using medical technology every day. The definition of medical technology is the application to society from science, and they are using science every day in what they do, whether it's a new drug, whether it's a diagnostic tool, they're constantly learning technology. When it comes to digital technologies, physicians are working with things like electronic health record systems, personal health record systems. They're now seeing new streams of data come into those systems that are coming from the iRhythms and the Alive cores. They're coming from the Apple Watches. And so they're adjusting their practices to these new data profiles, genetics. Again, you're seeing, if every time you go to the doctor now, you'll see a new genetic diagnostic or a new genetic tool for you to use to help manage your conditions. And I think the physician interaction with digital health is at the core of what Professor Topol set up in his 2012 book. I think that's something that really, when we look at this on a population health basis, that physician interaction with digital, as electronic health records move to swipe screens, as they move to voice integration and voice interaction, so they can actually make voice calls to their health records like you make voice calls to your Alexa or your Google Assistant or your Siri, that's when you'll see this kind of digital revolution that we're in the midst of really begin to take off.
All right, great. So Amrita has asked, looking 5 to 10 years forward, what can payer organizations do to invest in today to make sure needed digital health innovations can be democratized or made accessible or adaptable to reduce healthcare costs?
Another great question. And I think the health plan community in the United States is not a singular community. It really is made up of maybe 20 or 25 major health plans and integrated delivery networks, or IDNs, that are really hospital-based systems. And then there are a number that are intermediate sized, and then there are a number of health plans that are much smaller. And it really depends on the size of your institution. If you're a larger health plan, a larger IDN, then making those investments and taking some of that overhead capital that might be around to test and learn with some new digital interventions, that's a great plan. But if you're not, if you're either a mid-sized health plan or a smaller size health plan, it's important to understand exactly what the success metrics are. It's important to see evidence from other health plans and what they're doing. And so really digital becomes less of an innovation and more of a, kind of try to be a fast follower and not like a lost leader or an early pioneer.
Great. Javier asks, what is your opinion about the future on privacy over all this health information?
Privacy is absolutely critical, and it's not just a US issue. If you look at what's happening in the EU with GDPR, and again, you can Google that. I won't go into detail there since I have 4 minutes left. But if you look at what's happening in India right now, they have a national ID number, and there's a lot of uproar and controversy because a lot of folks don't want to be tracked by governments and that sort of thing. So privacy of your healthcare is quintessential. And if you look at what was begun under the Bush administration, Bush 2 in the mid-2000s started a part of HIPAA and started implementing and enforcing a part of the Health and Insurance Portability and Accountability Act that started looking at data breaches and patient data breaches. And if we look at, and again, these are all publicly available on the Department of Justice's Office of Civil Liberties website, you can see that there are enormous numbers of patient data breaches, not just happening across the smaller brands, but all brands of hospitals and health plans, et cetera. So patient privacy is critical, and I think in this era of we feel comfortable with Google reading our emails and sending us ads based upon that, we feel comfortable maybe a little bit less than it was maybe a year ago with Facebook reading our stuff and sending us ads. When we look at patient privacy, that is one of those walls where people start to, at least most people, start to put up a barrier and say, look, I want my medical records protected, and there's a little bit differentiation there. It's very interesting to see the difference of patient data in the US versus Europe, where Europe is mostly publicly funded healthcare systems. There is very little line to cross between commercial and public payer systems. There's very little integration there. Patients don't want their data going to private organizations at all. In the United States, it's very different. There's a lot more openness because we're kind of half corporate and half government healthcare system. There's a lot more openness with US patients to have their data being used by private organizations, as long as it's being done for research purposes and not for marketing purposes.
Sanjeev is asking, how critical will it be to unsilo patient data across institutions to move digital healthcare forward?
That's fundamental. And again, it goes towards that integration component. If we cannot find faster, better, cheaper ways of being able to take data from one department, say your emergency medicine department, and have it become an integrated component of an overall institutional record, you're not going to have that complete kind of digital human that Professor Topol talked about. And you're certainly not going to have the ability to manage population health issues and understand the institutional issues. And so that is going to be fundamental. And I think we've seen a significant amount of progress over the last 10 years around data standardization efforts in the United States. And now there's something called FHIR. Again, I would recommend you Google that term as well. And the FHIR standards are something that both HHS and CMS are promoting and utilizing, and then you're looking at as well NIH funding a lot of research grants that are using those standards to help improve that sort of data integration effort that you're talking about.
Great. This was a wealth of very good information. Thank you so much for being with us today, and thank all of you for your wonderful questions that came in. I look forward to your new program, Digital Health Strategy, in early 2019, if I'm correct.
That's correct.
Executive Education will be providing that, and we're great to work with you.
Thank you
very much.
Thanks for having me.
And thanks for coming.